की बात करते हैं because आपकी डिश की कल की थर्ड
Amit sir, please make me host.
Already you are host. Okay. I made you.
फर्स्ट वो है ना जो पावर हाउस से थोड़ा सा जस्ट आगे जाता है फर्स्ट गिर के उसके अंदर आ जाओ लेफ्ट साइड राइट साइड क्लास पेंसिल है कौन सा है आपके पास
Gaurang Shah sir, sorry for a delay. Actually, a last day for closing, that's why 5 minutes late.
Hello. Yeah. Join, sir. Dr. Paras is just joining. Once he's joined, we'll start the presentation. Who are presenting today? Who are answering?
Hello, good evening, sir. Sir, I'll be answering.
Who else?
Hello, good evening, sir. Dr. Rajesh here, sir.
Okay. First is Ajinkya, na?
No, sir, Dr. Shashwat from
Shashwat and Rajesh, na?
Yes, sir. Yes, sir.
Okay, okay. We are just waiting for a Paras to start. Okay.
Okay, sir.
Good evening, Hiren.
Good evening, sir. How are you, sir?
But how was your trip? All fine?
Very, yes, sir. Very nice.
Good, good.
Just returned at 7 o'clock.
Oh, okay. You're so dedicated. Huh?
Learn from you, sir.
Gite sir has joined?
Yes, sir. He was trying to join. I think there was some problem with the link. I think now he'll come.
We'll
Yes.
just see.
Yes, sir.
Can any one of you tell the definition? Shashwat? Shashwat, can you hear me?
Yes, sir. Dr. Rajesh here, sir.
Rajesh, can you just, before he joins Paras, can you tell me two things? One is the definition of the stricture urethra.
Sir, stricture urethra means scarring of the urethral epithelium and involvement of this corpora spongiosa, sir. Means mainly this refer to the anterior urethra, sir.
No,
Beta,
what is the
listen one
definition?
minute. Whenever sir question like this is asked, you have to be very clear with definitions. Okay.
Yes, sir.
So you have to be very clear what is the meaning of stricture, what is the involvement, what is it called in anterior urethra, what is it called in posterior urethra. Okay. Properly you should define.
Sir,
Textbook yes, go ahead. Tell
Yeah,
me.
Saswat, you can tell us.
sir, stricture urethra is a sir fixed anatomical narrowing in the anterior urethra, usually associated with spongy fibrosis.
Circumferential narrowing. Circumferential.
Yes, sir. Which will not allow instrumentation without disruption of the mucosal lining, sir.
Yes. So that is the right. So can you again compile properly and say, so that all those who are listening, they know what is the definition?
Sir, it is a fixed anatomical circumferential narrowing of the anterior urethra, usually associated with spongy fibrosis. And the lumen will not allow any instrumentation without disruption of the urethral mucosal lining.
Good. And if you have to classify, how will you classify?
Sir, there are the stricture urethra can be classified according to the etiology. It can be congenital stricture, sir. It can be a traumatic, and it could be inflammatory, idiopathic, or iatrogenic stricture. Then, according to the location of the stricture, from distal to proximal, it could be, sir, meatal narrowing or a submeatal stenosis in the fossa navicularis. It could be narrowing in the pendulous urethra, or a bulbar urethral stricture, or a bulbomembranous stricture, sir. In the posterior urethra, sir, it could be posterior urethral stenosis could be there, or a bladder neck contracture could be there, sir. And then there are, sir, ultrasound classification also of the stricture urethra. Then according to the USG classification, sir, it is based upon the obliteration of the lumen seen on sonography, sir. It is either less than 1/3 of the lumen is obliterated, or 1/3 to half, which is moderate, and severe is more than half of the lumen is compromised. Then, according to the, sir, EAU guidelines, it is classified from 0 to 5, with 0 being the normal urethral caliber, grade 1 being, sir, a subclinical urethral stricture, which is more than equal to 16 French lumen, and grade 2 will be, sir, 11 to 15 French lumen, which is a low grade stricture. Grade 3 will be, sir, a flow significant stricture, that is it will be from 4 to 10 French lumen, and grade 4 will be a nearly obliterative stricture, 1 to 3 French, and grade 5 will be, sir, no lumen at all. And then, sir, other classification is the divine classification given in Campbell, sir. It is grade from A to F. It is given, sir. A is a mucosal flap, and B is an iris constriction. C is a circumferential stricture with minimal spongy fibrosis, and D is complete spongy fibrosis. E is the fibrosis extends to the extra spongiosal tissue as well, and F is any fistulous connection to other organs of the skin.
Very good. You have covered almost everything, because these are the things which will be asked in your theory. In practical, everything may not be asked. So once you know this, you can write your answer very well. So you can always say it is congenital or acquired. That is a one classification. Second classification, as you said very rightly, as per the etiology. And a third is an anatomical situation where it is there. And when you write down anatomical, then you can write down meatal stenosis. So what are the causes of meatal stenosis? It can be instrumentation. It can be because of BUX. It can be because of circumcision, post-circumcision. Then fossa navicularis. It can be because of secondary to impacted stone, which has been removed, or maybe after circumcision. So step by step, you can say right up to the prostatic urethra. So that was what you elaborated, was a very good classification. Now Paras has joined, so I think we should start. Today, Achint is going to answer. No problem. So Rajesh and Shashwat.
Shashwat and Rajesh will answer.
Who is there?
Dr. Shashwat and Dr. Rajesh.
Okay, two of them answering. So we are going to have 4 cases. Paras, can you start now?
Yes, sir. So the first case is about a 40-year-old gentleman resident of Mumbai, married, tailor by occupation, presented with difficulty in passing urine since 5 months.
Okay. So Rajesh, this is a history.
Yes,
Now,
sir.
what are the questions you want to ask?
So first of all, this difficulty, how it's started, the difficulty in passing urine, how it's started, whether it was a gradual or it was a sudden in onset. Secondary, any history of trauma was there. The third one, any any history of chronic infection was there. Any history of infection associated with the scrotum, any history of associated with scrotal inflammation was there, recurrent scrotal inflammation, or
Okay. So Shashwat, can you just complete? What are the questions to be asked?
Sir, I'd like to ask about the onset of the symptom, whether it was sudden onset, insidious in onset, and the progression of the symptoms and the other lower urinary tract symptoms like the AUA symptom index and the quality of life scoring. I would like to inquire, sir. That is the frequency, urgency, any nocturia is having, straining is having, incomplete evacuation, or then along with that, sir, any hesitancy, if he is having any dysuria, any discharge per urethra, and also like to inquire about any hematuria, lithuria, or any flank pain, scrotal pain associated with that, and any history of trauma, instrumentation, or catheterization. And along with that, sir, we can also ask about history of whether he was in the past he's had recurrent UTIs, any inflammation or any pain in the scrotum or redness in the scrotum, and
any
in
history
the
of any
end,
sexual contacts.
Okay, sexual contact, hematuria, and history such as your puffiness of face, edema,
yes, sir.
lower limb, right?
And neurogenic
Yes, sir.
history also, sir. For completion, we'll have to ask whether any history of spine surgery or any weakness in the lower limb, any tingling or numbness, any constipation, whether it is associated.
Okay, fine. So Dr. Udedar and Dr. Gite, you want to add anything? Okay, Paras, go ahead.
So patient was asymptomatic 5 months back when he started developing difficulty in passing urine. There was increased frequency, which is progressive. In daytime, it is about 10 to 14 times a day, and nighttime it is 3 to 4 per night. At present, there is a gradual thinning of urinary stream, and patient has history of straining during the time of passage of urine with a sense of incomplete void post-urination. There is history of on and off fever with burning maturation since last 2 months. Fever is associated with chills. The IPSS score frequency is 3, urgency 2, nocturia 3, precipitancy poor flow 4, intermittency 2, straining 3, and sense of incomplete void is 3. The quality of life score is 2. There is no history of hematuria, lithuria, urethral instrumentation in past, discharge per urethra, trauma, high risk sexual contact. There no history of pedal edema, exertional breathlessness, or facial puffiness. No history of constipation, lower limb weakness. Patient is diabetic. At present, it is uncontrolled, and patient is presently on oral hypoglycemic. No other comorbidities. No surgical history in past. Family history is nothing contributory. Personal history: patient is vegetarian by diet. Bowel is regular. Bladder, lower urinary tract symptom as described before. Sleep is disturbed due to nocturia. Patient has no addiction to any form of alcohol, smoking, or tobacco. That's all from history.
Fine. So, Shashwat, from this history, what is your probable diagnosis?
Sir, my first diagnosis would be stricture urethra, sir, and my differentials would be, sir, it could be, sir, a neurogenic bladder, or sir, lower down we can.
Yeah, go ahead. You're doing well.
Sir, calculus disease is unlikely.
Yeah, exactly.
A prostatic urethral cal or a vesical calculus disease is bit unlikely, sir. But I like to keep them in the differential lower down, sir.
Okay. So, Rajesh, you want to say anything? Okay, fine. So basically, Shashwat, you must say that since this patient is young patient, he's only 42 years old, correct?
Yes,
And his history, he says that he has to strain, then the stream is becoming better, and all other symptoms. So considering that, the first thing that comes in your mind is a urethral stricture. Then it can also be because of like impacted stone, or it can be because of bladder neck obstruction, which is seen in younger age group, bladder neck hypertrophy, neurogenic bladder. Whatever you have said is perfect. So these are the differential diagnoses. Gite sir, you want to add anything to this?
Suspecting stricture urethra is okay, but patient had uncontrolled diabetes. And uncontrolled diabetes, so why not it is just underactive bladder? Why not it is just only a UTI? Why not it is just only prostatitis? Why not it is just only a settled anterior wall? Why not it is just only a phimosis? You have not examined. Why not it is due to only a stone in the prostatic urethra? So why not it is secondary to the bladder stone, small obliterating in between the bladder neck? So there is n number of differential diagnoses. We have not examined the patient. We have not done any investigation, and this is just obstructive lower urinary tract symptom. So possibilities are more. So you while telling in the exam, if you tell 5, 6, 7 diagnoses, that means that the examiner will judge he is thinking on broad perspective. If you tell first stricture means if I am examiner, I know okay, you have to diagnosis has told by someone else to you. So this should not happen. We don't know, because today the topic is stricture urethra, so that you are talking first as stricture urethra. It should not happen like thinking same thing in exam.
Yeah, but one of the diagnoses we'll have to say first. So in this case, with the differential diagnosis, one of the most probable diagnosis will be urethral stricture or urethral stenosis, and all other will be other differential diagnosis.
So the
Right?
next question is, why you have suspected stricture in this patient? What will be the pathology?
No, what I am asking you, Dr. Gite,
नहीं,
is
नहीं,
in exam, they
सर
have to
आपको
say the
नहीं, शाश्वत
differential
के लिए बात चल रही
diagnosis. No, what I am asking you is that they have to say the differential diagnosis. So they will have to say one diagnosis will be the first, second, third, fourth, fifth, like that. So in numerical, one diagnosis will be said first. Na? So I think.
Agreed, sir.
So,
सर आपके लिए नहीं बोल रहा हूँ,
no, I
स्टूडेंट्स के
know
लिए
that.
बात चल रही है.
Correct. I want them to answer. Okay, which they should put first and how to justify it.
हाँ,
So
so
they
what are the things made you to make a stricture as the first diagnosis at this juncture?
Shashwat, this is what sir is saying, that if you are telling in a differential diagnosis, you are giving 7 differential diagnoses, and the first one you are saying that it is a stricture urethra. Why you are thinking that stricture urethra is the most probable diagnosis compared to all other 6 or 7 differential diagnoses? So you justify.
Yes, sir. Sir, it was he's 40-year-old and it is insidious in onset at that age. And he had obstructive symptoms along. He has mixed lower urinary tract symptoms with an obstructive component as well. So before UTI, it could be a super added UTI, sir. That's why I'd like to keep a stricture diagnosis before prostatitis or other anterior urethral wall, or and he has no history of lithuria, and that's why, sir, I'd like to keep calculus disease lower down, sir.
Okay.
Fine. So what Dr. Gite is saying is that whatever sequence you are putting, you must be able to defend yourself and justify it. And the examiner should not feel that you know the case beforehand and you are answering. That is the most important thing. And for that matter, you should not say that it can be because of, some other disease like a malignancy, intraluminal malignancy. No. So what is the most probable diagnosis that you must say, but you should be able to defend it. Fine. Paras, go ahead. Okay, so now next what? Saswat?
Sir, I'd like to do a general physical and a systemic examination along with the local examination of the genitalia and perineum and focused urological assessment.
Fine. So Rajesh, what are the important things you are looking for?
Sir,
In general examination, what are the important things? In local exam, I mean in systemic and in local examination. Important things, just tell us.
Sir, in the general examination, patient orientation, sir, patient consciousness, whether he oriented or not, sir, whether conscious, semi-conscious, his vitals, sir, BP pulse. Then after general examination, in the any pallor cyanosis, any suprapubic fullness, then any scar mark, umbilicus position. Then in the perineal examinations, both a scrotum, any phimosis, any.
Rajesh, before you go to perineal examination, in general examination, I would have been happy if you would have talked about hygiene and oral hygiene, because we are discussing stricture urethra.
Yes, sir. Yes, sir.
That would have been presence of mind. Go ahead.
No, someone has asked that in examination, we will be having only 45 minutes. See, the idea is when we are presenting these cases over here, we want all of you to ultimately cultivate that practice, that within 5 to 7 minutes, the repetition of these things will help you, that in 5 to 7 minutes, you finish your examination and everything, and you are, in 10 to 15 minutes, you're done proper examination, you're thinking, and now you're ready. That is the most important thing. Here we may take total half an hour, but in exam, in 5 to 7 minutes, you are going to finish.
So that's why these classes are there to make you a perfect in exam.
Yes.
So, Shashwat, if I am at your place, I will tell like first I will explain the chip complaint, then I will explain all lower urinary tract symptoms, then I will ask history 1, 2, 3, 4, 5 like acute urinary retention, UTI, post-void dribble, suprapubic pain, recurrent repeated emergitis, then history of infertility, young patient due to obstructed ejaculation, meatal stricture in terms of deviated streams. If a patient is old, then history of TURP, patient is young here, the passage of stones, then history of trauma, then history of urethral discharge. This all things, then history of renal failure. If one go, you make 10, 15 negative positive history for each diagnosis and you mug up that. So
Yes,
that
sir.
if you are asking, if you are telling that negative history, examiner should know you are talking about diabetes, you are talking about tuberculosis, you are talking about trauma, you are talking about neurogenic bladder, you are talking about prostate. ये 3, 4 symptoms in one sentence बना के उसको mug up कर दो.
Yes,
And
sir.
that will applicable for each and every case. Okay. In general examination, if you are expecting a stricture as a first diagnosis, then what are the problems with stricture that will display in general examination? So the stricture and associated obstructive uropathy, renal failure, the puffiness of face रहेगा, anemia of CKD रहेगा, then generalized body swelling रहेगा. Any history of generalized exam करते समय abdomen में आएगा तो एक आधा scar mark previous suprapubic trocar का scar mark रह सकता है. अब भी distended bladder रह सकता है. तो ये जो targeted to your case पहले बोलो.
Yes, sir.
Otherwise, there is no lymphadenopathy and there is no cyanosis. Then I will ask why there is cyanosis in your case. Why? What are the problem with this patient? You are seeing about cyanosis.
Yes, sir.
Okay.
And as Dr. Hiren said, hygiene is also very important in these days.
Agreed.
Both of you are doing very well. We are just interrupting because we are training you to get ready for the exam. So don't be disheartened, okay? Both of you are doing very well.
Fine. Check. Paras, go ahead. Paras.
So there's no significant finding on the general examination. On local examination, external genitalia is well circumcised. No, the external genitalia is normal. Patient is circumcised. Penile meatus is normal. All hernial orifices are normal. Scrotum, bilateral testis normal, palpable, non-tender. No palpable urethral thickening or mass. Per rectal examination, anal tone normal. No fissure fistula. Prostate normal in size, firm in consistency, smooth surface, non-tender. Rectal mucosa mobile. No blood on gloves. Per abdomen examination is grossly normal. Systemic examination is normal.
Fine.
So,
Shashwat, now,
you want to add?
Shashwat, you want to add anything?
No, sir.
I want to ask what is the color of glands?
Yes, sir.
Is it important?
There is no sign of inflammation or BXO over gland.
So if it is whitish,
Pink.
that may be just a lichen sclerosis.
Yes, sir.
Okay. And lichen sclerosis again, it will go inside. So as per the classification, it will go up to the proximal urethra also.
Yes, sir.
But at least up to the distal penile urethra, it is common. And the external presentation of that is only the white discoloration or VXO.
Yes, sir.
That the palpation of the urethra along its longitudinal axis. Any palpable stone, hardness, induration, sinuses, that may this may be just there may be tuberculosis. You don't
Yes,
know.
sir.
So while telling skin of the prepuce, color, if their prepuce is present or absent, if it is there, then the skin, color of the prepuce, then color of the glands, then meatus, is it pinpoint meatus visibly? or normal meatus is centrally placed or hypo or EP, then is there any surrounding skin or along the urethral area? Is there any scar mark prior? Is there any sinuses, skin tags? Then is there any fistula? Is there any palpable hardness, tenderness, or is there along the urethra? These all things you have to see and tell, and as well as the scrotum. The both test is about feel about size and shape and consistency and tenderness
Yes, sir.
of the testis. Okay.
Yes, Paras, go ahead. So, okay, Shashwat, this is the total history. Now, what you want to ask?
Sir, I'd like to request certain investigations, sir. A urine routine and routine blood test, including CBC, renal function test, the blood sugar levels, if possible, fasting and PP, and an X-ray KUB and an ultrasound of the KUB region, sir.
He has got recurrent infection. You don't want to have urine culture and sensitivity?
Yes, sir. After urine routine, I'll like to request a urine culture also.
Fine. But in this case,
Are you interested in calculating the IPSS score?
IPSS score, sir, 20 tha, sir. In the
Calculate
sir.
कर Okay.
Okay. Bye. Show them investigation.
So on urine routine microscopy, the WBC are 50 to 60 per high power field, RBC are 5 to 6 per high power field. Bacteria is present. It's Proteus species, sensitive to multiple antibiotics. As shown.
Okay. Next.
Blood investigation, hemoglobin is 12.6, TLC is slightly raised 15,660, platelet is normal, creatinine is 1.28 with normal reference range up to 1.2, sodium is 131, potassium is 4.8, and HbA1c of patient is 9.2. On sonography of abdomen, there is mild bilateral pelvic ileal system fullness. Pre-void is about 250 and post-void is about 225 ml. Prostate is about 12 grams.
How much is the post-void?
225.
225, sir.
And what is
Almost
the pre-void?
50%.
450,
sir. 50% is there.
So, what next?
Sir, patient is having significant post-void residual urine along with active UTI, sir. And we'd like to with bilateral mild fullness of the pelvic ileal system as well. So we'd like to put in a catheter, sir, if possible. And we'd like to go for a small lumen catheter. If it fails, then we'd like to opt for an SPC, sir.
So your diagnosis is already confirmed. It is stricture urethra.
Sir,
because at this juncture, what are the problems in front of you? Uncontrolled diabetes.
Yes, sir.
Next problem, uncontrolled infection. Next problem, bilateral mild PCS fullness and significant post-void residue.
Yes, sir.
So we have to tackle all these three things parallelly.
Yes,
like
sir.
controlling of sugar, physician opinion, anti-diabetic treatment, culture specific, antibiotic, and drainage. So how will you do the drainage? At present, he is passing the 50% urine he is passing.
Yes, sir.
Okay. His creatinine is how much? Normal.
Normal.
TLC slightly raised probably. TLC kitna tha pata nahi, lekin TLC may have been raised.
Yes, sir. 15,000.
So it is a active UTI with outlet obstruction. It may be infravesical or at the level of vesicle. Okay. So how to diagnose at this juncture? Are you going to go for some invasive investigation? No.
No, sir. I'd like to start
So you
parenteral
can.
antibiotics, control the diabetes, and
Is
then,
is it possible to go for a uroflowmetry?
sir,
No,
ideally,
sir.
no, sir. Actually, once the UTI settles, and we'll repeat a urine RM after 3 days of starting parenteral antibiotics, and once the urine RM shows decrease in the WBC count, and then we can go for a invasive testing, sir, or uroflowmetry.
Uroflowmetry is a non-invasive investigation.
Ji, sir.
So uroflowmetry can be done. It can give indirect evidence or clue towards there is obstruction or not. Okay.
Yes, sir.
So if there is problem is due to some infection, at least he may have Qmax, adequate Qmax. But if it is due to underactive bladder or infravesical obstruction in terms of the narrowing of the lumen of the urethra, then he may have very low Qmax and low average flow.
Yes, sir.
So that is indirect evidence which will support your clinical judgment. And there is nothing wrong in doing the uroflowmetry because it is not invasive.
Yes, sir.
And already you have started the antibiotic. So after starting the antibiotic and control of the sugar with post-wide residue of 50% post-wide residue and uroflowmetry, if it has done, the curve is, for example, it is a very low Qmax. Your first aim is to decompress the bladder.
Yes, sir.
Okay. So we don't know there is the inside the urethra there is obstruction, where is the obstruction and how much is the obstruction. Okay. And RGU in the sitting immediately is not advisable.
Yes, sir.
So it is indicated in this particular patient, you can go directly for suprapubic catheterization.
Okay, sir.
Place the suprapubic, give the urethral rest, give antibiotic for adequate amount of length or time, control the sugar, and go for invasive investigation. That should be the plan.
Okay, sir.
So Dr. Gite has explained you. Now this is a uroflowmetry. Can you just comment on that? Paras, just make it little big.
Sir, voided volume is 245 ml, sir.
Yeah.
Qmax is 12.9 ml per second, and average flow rate is 6.5 ml per second, sir.
So this is for
Voided
his
time is
age group, it is definitely obstructed.
low.
It is not a normal, correct?
Yes, sir. Yes, sir.
Yeah. So now you have got a two choice. One is, I think MBL has said that a gentle attempt of catheterization with a small size catheter, you can do it. And as Dr. Gite said, directly go for a suprapubic catheterization.
Yes, sir.
Right?
Yes,
So
sir.
Paras, what was done?
Sir, after seeing this uroflowmetry picture, the 3-4 prominent things you must explain. First is a hesitancy.
Yes, sir.
While starting a flow, there is a lack of near about 9 to 10 seconds. Wait, Paras, wait.
Paras, go ahead. Okay.
Wait. So there is the start of the flow is after near about how much seconds? Some 8, 9, 10 seconds. There is hesitancy definitely. The Qmax maximum is reached is near about, he told it is 12. Okay. But it is like a very, and the time to pass the urine is also lengthy. Okay. So the time to pass is longer duration than hesitancy, and Qmax it is shown at one spike it is only 12.9 they have written, but it looks like less than 10 average. If it is taken, it is less than 10. So it is obstructive curve. Obstructive curve with poor flow.
Yes, sir.
So what next? Abhi doing a catheterization trial of giving a trial of catheterization in a state having an active infection with when there is a suspicion of infravesical obstruction. If it is an expert person, okay, one gentle try small catheter with proper injectable antibiotic, agreed as an option. It is better to go for, if in exam, it will be better. I will not touch the urethra. I will not disturb the urethra. I will go and place the SPC.
Yes, sir.
So,
Fine.
क्या किया है पारस बोलो?
पारस क्या किया मतलब?
A gentle Foley catheter attempt with 14 and 12 French was done, but it failed. Patient was taken up for cystoscopy with VIU as patient was not willing for a suprapubic catheterization. Foley catheter was a VIU was done and a 18 French Foley catheter was placed, which was removed after 5 days, and patient passed urine adequately. Patient was advised for a regular urethral dilatation, but patient was non-compliant. After 3 years, the same patient presented in emergency with painful acute retention of urine. There was gradual thinning of urine with lower urinary tract symptoms with on and off burning, maturation, and fever since 1 year, for which patient was consulting a local practitioner. What next to be done now?
So here, they tried a Foley's catheterization and it is unsuccessful. So went for cystoscopy or cystourethropy, cut the stricture and place the catheter. Okay, in private practice or nursing home practice, it is okay because it is a matter of money, matter of hospitalization, number of off work days. These are the reasons the patient want early treatment and go home. But if in exam, you have to tell in this particular patient, I will place the SPC. Wait for to resolve the infection. I will go for RGU. MC, I will assess exact length of stricture. We don't know. Going blind with the copy, and if there is a longer, very narrow urethra, and wire is not going, then what? Then intraoperative we will do. So doing some or invasive is not a good idea. So the answer for this particular patient in exam is SPC. Wait for 2 to 3 weeks. Repeat at least urine routine. The plenty of pulses when decrease from 50 to near about 4 to 5. Then go for the RGU and MCU. Assess the length of the stricture and plan as per the length, number, site of the stricture. Length of the stricture, number of the stricture, site of the stricture. Okay, if it is a very flimsy diaphragmatic, now what is the role of VIU? At current situation, the role of VIU is very limited. Practically, a number of people are doing VIU only.
Yes, sir.
But theoretically, the current status of VIU is limited to only a flimsy diaphragmatic stricture. And the people were comparing VIU with non-transecting. And the result of non-transecting is better than the VIU because VIU, doing a VIU, it will heal by again fibrosis.
Yes, sir.
And multiple procedures, there is a role of people. Now there is no role of second VIU also.
Yes, sir.
Still, practically, the first success of the VIU after first VIU is 15% to 75%. There is wide range. Then some people will try second VIU. But third VIU, no third VIU. I will tell no second VIU also.
Yes, sir.
You try once. If it is not possible, go for a definitive treatment. So in this particular patient, the patient may not have come for 3 years. After taking a temporary treatment, because total successful treatment happens only in 15% of patient, probably 15 to 75 is the range. So after 3 years, he may have again a blocked urethra. 3 years, that means the VIU done is very excellent. It will work for, it has worked for 3 years.
Yes, sir.
But majority times VIU may not work for 3 months also. If the length is too long and the spongiofibrosis is too high, it will block within a month or 2. So it is a temporary stopgap arrangement for definitive treatment.
Yes, sir.
So at the end of 3 year, Paras, go ahead.
Paras, go ahead. So patient came after 3 years.
Now the patient has presented after 3 years. Patient was having lower urinary tract symptom for 1 year, but patient was not consulting any urologist.
So he came with a retention of urine. So Shashwat, now what will do?
Sir, now I'd like to counsel him and put an SPC and investigate.
Fine. So again, there are, as you said very rightly, as Dr. Gite said, this is the answer. Sometimes some people do, their book says that again, one attempt, okay, to put the small catheter, and if it fails, supra BB. So both, but you have to justify.
Yes.
Fine. What we did, Paras, go ahead. See here now we are showing you exactly what has happened. That doesn't mean that this is what you have to answer in exam. What Dr. Gita is teaching you, that is the right thing. So you know what is practically done in a small nursing home or a small place routinely, but what is the right thing to do? Okay. So this way you will be able to understand what is correct and what you should answer in exam. Paras, go ahead.
So in emergency, infant feeding tube 9 number was placed with difficulty. Then
Yeah.
the patient was investigated. There were on urine routine microscopy, the WBCs were 100 to 120 per high power field. RBC were 4 to 5. There was E. coli in the culture. 10 raised to power 5 colony forming units sensitive to amikacin, meropenem, and cholesterol.
Go ahead.
On blood investigation, hemoglobin was 10, TLC was 15,000, creatinine is raised to 2.4, and HbA1c is decreased to 7.6.
Yes, Shashwat, what?
Sonography was done.
Yeah.
The pictures are shown.
Can you read this sonography?
Yes, sir.
Sir, both kidney is looking hydronephrotic, sir.
Yeah.
Hydronephrotic, sir.
Okay.
Bladder wall is irregular and thickened, sir. Bladder wall. In the
Sir, renal parenchyma also appears a bit thinned out, sir, with gross hydronephrosis. And we can, sir, till the VUJ, we are able to see the ureters. The bladder is moderately distended, sir, appears to have thickened wall, and diverticulum, sir, I cannot make out.
Yeah, difficult to see. Fine. So it is a bilateral ureteronephrosis with the, yeah. Paras, just read out.
So on sonography, both the kidney are mildly enlarged. Right kidney is 12 into 7.3 centimeter gross hydronephrosis with thinning of parenchyma. Left kidney is 12 into 6.3 with severe to moderate hydronephrosis. No obvious calculi seen. Urinary bladder is well distended with multiple mobile echoes and irregular bladder wall thickening. The wall thickness is 6.9 mm, pre-void is 331 and post-void is 280 ml. The prostate is 20.7 cc.
Fine. So now next, what you will do?
Sir, we'd like
Again,
to,
again, you are to the square one, correct?
yes, sir.
Yeah.
Again, sir, we'll like to start parenteral antibiotics, control the diabetes, and wait for the infection to settle down, sir. And we have already placed a feeding tube. If it is displaced, if it is not secured, then we'd like to counsel again for SPC, because
Fine.
it affords better drainage of the bladder, and because
Yeah,
it's also
and
having
as he
hydrated
said very rightly, you can have a better drainage, you can control the infection, and you can give rest to the urethra, and you can plan out the surgery.
We'll also like to monitor the creatinine fall in the serum creatinine and the electrolytes, because
Right.
there could be a post-obstructive diuresis phase for 48 to 72 hours. And if the renal parameters are increasing and the infection is decreasing, and then once we'd like to, after 3 days, we'd like to repeat urine routine microscopy if the pus cells are reduced. And then we'd like to go for a anatomical RGU, MCU for the patient, sir. To
Yes,
delineate
Ashwath, what is hurry in doing the RGU? You have placed the SPC. Take some breath. Let patient also to take some breath. Within 3 days, in presence of antibiotic, under antibiotic cover, forcing the things, how it is going to help?
Next, book recommends waiting period of at least 4 to 6 weeks. Once.
Then so what book recommends that only you tell in exam? The concept of urethral rest, if you see, the urethral rest should be at least 2 to 3 weeks. No?
Yes, sir.
SPC, history of urethral manipulation or history of SPC, 30 days prior to reconstruction and 6-week rest. So 6-week rest is required.
Yes, sir.
So doing RGU now and doing RGU after giving the urethral rest, so there will be difference. RGU in presence of infection, inflammation, and RGU when the infection, inflammation is settled. So the exact picture if you want, so no need to go for to do RGU immediately. Na?
Yes, sir.
You are unnecessarily creating problem for yourself in exam. So if I am at your place, I have placed the SPC, sir. I will give antibiotic injectable followed by oral antibiotic for 7 days. I will ask him to come after 1 month for change of catheter. I will recheck his general all the symptoms and as well as that laboratory investigations. I will repeat it and I will go for, if everything is settled, then I will go for the RGU.
Yes, sir.
That will be the proper.
Yeah.
Yes,
Good.
sir.
Fine. Yes, Paras. Just tell what we did. Paras.
Yes, sir, yes. So after giving antibiotics, the patient underwent a uroflowmetry. So average flow was 2.5 with Qmax of 3.4 ml per second. Voided volume was 178 with voiding time of 38 seconds. So we did an RGU and MC.
How so? Your feeding tube is inside only, so that may be the reason. Probably they may have a plan for RGU and MCU. But at this juncture, if you avoid the RGU and MCU in presence of infection and uncontrolled diabetes, patient is in near retention, urethra will be inflamed, swollen. So it is better to avoid the invasive investigation at this juncture and go for SPC. So still anyhow they have done the RGU and MCU, so we'll see the RGU and MCU.
Yeah. So in exam, you again say the same thing that you like to do suprapubic, you will like to wait, and later on you will do RGU. So now this is an RGU. What are the findings? Shashwat,
Sir,
are you happy with this RGU? It is done properly,
No, sir.
right?
Sir,
Okay,
Sir,
then how to do RGU? You
Sir,
people are
sir.
doing or radiologists are doing?
sir, we are doing, sir.
Sir, we
Yeah.
are doing, sir.
Okay, now tell me how you do it.
Sir, we place the patient in a right lateral decubitus position with 45-degree inclination. The dependent leg is flexed to, the thigh is flexed to 90 degrees, sir, and the overlying leg is made straight. And after painting and draping, sir, and we put the penis in moderate traction, and we introduced the adapter with Urographin 50% diluted, 25 ml, and we inject slowly, sir.
Slowly means what is the flow rate? Approximately. Yeah? So if you are having 20 cc of syringe, within how much time you will
About
inject?
sir 8 to 10 seconds we take, sir.
Okay, 10 to 15 seconds, fine. And
Sir, we don't take scout images actually, but it is recommended to take a scout image also and then inject the contrast, sir.
Why you don't take scout images? Because it is your protocol.
Ji, sir.
You don't want to do, if you in the non-traumatic patient, it's okay. You don't want to assess for the fracture in traumatic patient. You don't want to see for any stone disease in the contrast film.
Yes, sir. We should take a scout film, sir, and then proceed with the contrast.
You have given a right position radiologically.
Sir, yes, sir. The thigh should be flexed to 90 degrees, sir. And
how will you confirm on fluoroscopy or radiologically you have given a correct position? This is a simple question, usually asked in exam.
Sir, obturator foramen is visible, sir, only one side.
Only one obturator foramen.
Yeah. So only one obturator foramen should be seen. Why there is a penile stretch? Why want to give a penis in stretch?
Sometimes there are mucosal valves, sir. So giving moderate stretch will straighten them out. And
Two reasons.
the
And
pinoscrotal,
superimposition, to avoid the
sir, the
superimposition of the anterior
pinoscrotal
and posterior
angulation
urethra.
is well delineated, sir.
So there are two reasons, that flattening of the mucosal folds and straightening of the pinoscrotal angle.
Yes, sir.
Then if you have given a penile stretch too high, then it will look like a panurethral structure.
Yes,
if
sir.
you give a penile stretch too low, then angle will not be gone.
Yes, sir.
Okay, so the stretch should be moderate. Okay, so what is meant by autourothrography?
Sir, patient is asked to inject the contrast, sir, so that radiation exposure for the operator is reduced. But we have never done, sir, that.
But you must know, na? No.
Yes, sir.
Now we are also not doing autourothrography. But
Yes.
that theoretical question you must know.
Yes, sir.
So how using what things you will injecting the contrast?
Sir, Foley's catheter 8 French is introduced into the navicular fossa, and 3 ml saline is inflated, sir.
Really doing like that only?
Sir, we have never done, sir.
Infant tube or sometime.
So the theoretical answer is 8 French Foley's with 1 to 2 ml and Foley in the fossa neocularis. That is the answer in exam. But the examiner knows no one is doing like that.
Yes, sir.
So any other thing? कौन टिपड़े कैथेटर्स रहते हैं? ब्राउडनेस क्लैंप लगा के या फिर हम तो यूजुअली वाच पीस से बांध के उसको ट्रैक्शन दे देते हैं. फोलिज
Yes.
कैथेटर एग्जाम में परफेक्टली फोलिज कैथेटर बोलना है, और तुम्हारे पास क्या होता है अगर ऐसा पूछा है तो फिर जो होता है वो बोलना है. 10cc syringe with nozzle inside the glandular urethra or feeding tube just inside. What is the problem, Rajesh, with feeding tube?
Sir, it will slip out, sir, or it can go inside also, sir.
No, the main problem of feeding tube is it will bypass the stricture. If the stricture is in glans or postnuclear,
Yes, sir, sir.
so if the feeding tube you are using 8 French feeding tube will go up and the stricture will be missed, and RGO looks like a normal. So this is the problem with feeding tube.
Sir.
So how to visualize the posterior urethra?
The posterior urethra, we should not comment on ascending urethrography. For that, we should.
That I know, boss. While doing
Yes,
the RGO,
Sir, MCU.
to visualize the posterior urethra. That's what I am asking. You are doing RGO.
Yes, sir.
Contrast is not going behind the sphincter. Then
Yes, sir.
is there any way to visualize the posterior urethra?
Sir, we ask the patient to relax.
Which mechanism of patient will relax the posterior urethra and urethra get open? When urethra get open?
Ask
Sir,
it to also.
If you ask the patient to pass the urine, try to pass the urine, what will happen?
the sphincter mechanism
Whatever normal urethra as a normal physiological mechanism of micturition, it will get open.
Yes, sir.
Except the stricture thing. And if the lumen is maintained, contrast will go up.
Yes, sir.
So the only simple way is ask him to try to pass the urine during examination. That will make the posterior urethra get open. Or another way is autourothrography. Ask himself to do it. He will get relaxed by himself. So there is no anxious spasm. Okay.
Yes, sir.
Some people also give alpha blocker.
Yes, sir.
Yes, sir. Some people will also give alpha blocker. Again, the RGU, gravitational RGU, dynamic RGU, then relaxed RGU and holding RGU. There are 4 or 5 types of RGU. Now it is not RGU, it is RUG, retrourothrography or gram.
Yes, sir.
So, what is meant by dynamic RUG?
Sir, dynamic is under fluoroscopy, sir. We actively try to see the relaxation of the urethral sphincter, and that way, sir, any spasm of the patient is avoided, sir.
Now, the whole process of the RUG is continuously seen under continuous fluoroscopy.
Yes, sir.
That is dynamic RUG.
Yes, sir.
Okay, what is by gravitational RUG? Sir has told any other way to go for RUG. So what is by gravitational RUG? So that there should not be any intra-oscillation or extra-oscillation of the contrast to avoid such complication. What is by gravitational RUG? जैसा gravitational MCUG है, VCUG है, वैसे gravitational RUG. So
Yes, sir.
either you push the contrast very slowly, equal to the gravitational force, or just connect the contrast filled tube to the that catheter or feeding tube inside.
Yes, sir.
And let the contrast go with some slight stretch on the penis of the penis over the thigh. Okay.
Yes, sir.
So these all questions are related to the RUG. So now if you are talking about investigation, there are other investigations also. So in spite of RUG, I may go for sonourothrography.
Yes, sir.
So what is the role of sonourothrography?
Sir, it can delineate spongy fibrosis also, and it can assess the length of the stricture, sir, simultaneously.
So as you are important in the lumen, you should also interested in the lumen, you should more interested in the spongiofibrosis.
Yes, sir.
Okay. So if you want to assess the spongiofibrosis, the best way of doing the assessment of spongiofibrosis is sonourothrography.
Yes, sir.
Okay.
Ji, sir.
So, but it is not routinely done. If it is done at your place, you definitely tell it in the exam. If it is not done, then no issue. So what is the limitation of sonourothrography?
Sir, it may underestimate or may not be able to define the spongy fibrosis completely.
Technical expertise, मुझे नहीं आता करने को.
हाँ, sir.
Limited evaluation of the only distensible urethra. Because
Yes, sir.
sonourothrography means not only placing the transducer over the urethra, you have to fill the urethra with jelly.
Jelly. Yes, sir.
So that means the urethra should be stretchable or elastic, not rigid.
Yes, sir.
Okay. So these are the problems with sonourothrography. Then we will discuss rest investigation while discussing the post-traumatic strictures. Okay,
Yes,
we'll go ahead.
Now, can you see the bladder?
Yes, sir.
The shape is
Sir,
the for Christmas tree type.
Ear
not
shape.
so there must be some neurogenic
urogenic
element.
component as well.
Yeah.
Yes, sir.
Correct. Yeah, go ahead. Yeah, go ahead. So what you will do now?
Sir, after the control of infection and diabetes, sir, since the bladder looks we are suspecting neurogenic involvement as well, we can we can go for a urodynamic study, sir, to evaluate for the underactive bladder component and proceed for if it is normal, sir, then we can proceed for surgical management, sir.
That's what. You have a clinical diagnosis of a stricture urethra.
Yes, sir.
Only feeding tube is going inside. Okay. So there is a definitely a infravesical obstruction. So in spite of going behind that neurogenic bladder, you first tackle the stricture urethra.
Okay, sir.
Release the resistance provided by the outlet or infravesical obstruction and see how bladder behaves.
Yes,
okay.
Sir.
So first in this particular patient, placement of the SPC and going for MCO and RGO after 4 to 6 weeks and assessment of the structure length with or without the help of ureteroscopy with pediatric scope or 6 French ureteroscope. And as per the structure length, site and spongiofibrosis, you have to plan the treatment. This will end of the story for this particular patient. After you have given a proper treatment, and in spite of that, if it is in spite of having a normal lumen and patient still is having a voiding symptoms, then you can go for whatever investigation you want to go for bladder.
Fine. So Paras, just tell them what we did.
The patient underwent cystoscopy with VIU. There was a stricture in the bulbar and the membranous urethra with a suprapubic catheterization. Per-urethral catheter was removed, but the patient was kept on SPC. After 5 months, patient presented again with the uroflowmetry as shown.
Okay.
Fine.
So they have gone for again cystoscopy and VIU. Okay. So
fine. We'll go ahead. Okay, Paras. After that, what we did?
So patient was BMG urethroplasty with
So after two
SPC
times we did the VIU, it has failed. So we have done BMG urethroplasty. Okay. After
Sir.
controlling his infection with a suprapubic catheter.
So for, sir, again, okay. So if you are planning for any surgical intervention, the stricture should be stable. That is one requirement. No instrumentation within the 3 month of the 3 month prior to the BMG urethroplasty. If you are planning reconstructive surgery, then there will not be any history of repeated dilatations or self catheterizations, because if doing a VIU and place asking him to do a self catheterization to make open the urethra or self calibration is theoretically as well as guidelines wise is not indicated. Then after settling the disease only and assessing the length of the stricture exactly, so it is a panurethral stricture or only anterurethral stricture, because here up and down scopy again it is requirement, ASU and MCU is requirement, then doing a scopy with URS is requirement. All these are for preoperative evaluation for assessment of the length. And on scopy, you can see the color of the epithelium, then elasticity of the urethra, then rigidity of the stricture, how much rigid it is. And as per that, as per the lumen, you have to plan for the BMG.
Yes, sir.
So BMG again, you can plan for dorsal only, dorsal inlay and ventral only. These are the three ways of placing the BMG. If
Yes,
it is BMG is not available, then preputial skin, tunica albuginea, veins, if the lumen is adequate, and if we just want to increase the lumen of the urethra in small size, then vein can be also used. So these are the ways of the augmenting the urethra using the grafts.
Yes, sir.
The lumen of the urethra is less than 4 French. Theoretically, we keep it as a 6 French, but theoretically, if it is less than 4 French, then you have to either go for a stage procedure or flaps.
Yes, sir.
So this is about the short theoretical aspect of this case.
Yeah. So now what happened next? Paras.
So after 2 years, patient again presented with decreased urine output with pedal edema and breathlessness since 3 days. On examination, pedal edema with bilateral basal breath, the lung field with facial puffiness was seen. Serum creatinine at present is 6.6, hemoglobin is 8.2, TLC is 12,400.
So anyway, I'll cut the story short. He was catheterized, but the catheter went very easily inside. Hardly any urine was there. And sonography showed, Paras, just show them what is the sonography.
We did a plain CT.
Okay. So we had done this CT scan, non-enhancing, and it was showing bilateral hydrouretronephrosis.
Yes, sir.
And since the creatinine was not coming down, bilateral degestenting was done. So after doing bilateral degestenting, what is the creatinine had come down to 3.2. And so now we have removed the digestant. Okay,
Today
so
we
and
have
now
to
we are
go to
waiting. Fine. Shall we go ahead with the second case, sir? Yes, Paras, go
इसमें
ahead with the
लास्ट में
second case.
एसपीसी है क्या अभी? ये
Pardon?
पेशेंट को एसपीसी है क्या अभी?
नहीं, SPC,
Is this
the long
patient
back.
have SPC?
After BMG,
now.
No, now nothing. Because he is passing urine well, his urethra is normal.
Okay, sir.
Paras, second case. Paras, tell the
a
history first.
17-year-old boy. A 17-year-old boy underwent a road traffic accident, presented to us in emergency with pain in lower abdomen and inability to pass urine. On examination, patient is hemodynamically stable. There is tenderness present in the lower abdomen, particularly in the hypogastric region, with slight abdominal distension. Pelvis compression test is positive. Bladder lump is palpable. There is blood seen at the external or urethral meatus. Chest X-ray is normal. Ultrasound fast shows bladder, distended bladder with internal echoes.
So in this case, what you will like to do? He is otherwise fine. All C's, his CT scan, everything is normal. He has got only pelvic injury. Shashwat.
Yes, sir. Sir, in this situation, sir, we may attempt one gentle attempt at catheterization. And if it fails, we would like to put an SPC. And along with that, sir, we'd like to obtain an orthopedic consultation about the pelvic fracture, whether they want to do an open reduction internal fixation, so that at the same time we can plan a tunneled SPC if they are going to operate, sir. If they are planning a conservative management, then when we have obtained a bladder drainage, we'd like to keep him under observation and plan a definitive repair and investigation later.
So you have been called in the casualty with this history, this history, and patient is in front of you. I will go there and I will assess his ABC.
Yes, sir.
I will check he is hemodynamically stable or not.
Yes, sir.
Parallelly, the orthopedic as well as general surgery consultation to learn the associated injuries. I will place one IV cannula, start the IV fluid, give one dose of antibiotic, and go for fast examination, that is bedside ultrasound. Bladder is distended, so blood at meatus. First investigation in my mind theoretically is RUG.
Yes, sir.
RUG will give me assessment that there is a complete rupture or partial rupture. Tear is complete or partial. If it is a partial, then I may try to bridge this tear site with gentle attempt of perioral catheterization.
Yes, sir.
Our primary realignment, that is another indication if patient is hemodynamically stable.
Yes, sir.
Otherwise, if there is a complete rupture and blood at meatus, direct SPC.
Yes,
One gentle try perioral catheterization with prior or after RUG is again a controversial thing. Few authors tell the gentle try should be given and few tell no need to give the try, it will make partial to complete.
Yes, sir.
As reported, 50% cases, catheter will go easily, walk in easily. And it will avoid the emergency surgery and decrease the length of the stricture and decrease the density of the stricture in future. So these are both, you can depend by both way. In exam, if I am a student, I will tell, sir, there is a blood at meatus. Emergency investigation is RUG. I will see that it is a complete or partial rupture. If it is a partial rupture, I will try to go for one gentle perioral catheterization blindly or endoscopically if it is a partial. Okay. So then immediate primary realignment and delayed primary realignment. There are two types of realignment.
Yes, sir.
So the concept of realignment and success of realignment, the ways of realignment, these are very theoretical topics. So we will discuss sometime now. Sir, आगे चलते sir.
Yeah, go ahead. So tell us what was done. Paras. So patient had undergone suprapubic.
Underwent a suprapubic catheterization. What next to be done now?
Okay, so after suprapubic catheterization, Shashwat, now how will you follow up?
Sir, after the
Patient
stabilization
is
of the patient,
hemodynamically stable. Orthopedics opinion was taken and they advise a conservative management. Patient is discharged with SPC. Now how to follow up the patient?
So, Shashwat, wait for some time. Sir,
Yes.
we will answer that 3-4 questions. That is, Anchit Bajpayee has asked how to exactly assess the spongiofibrosis. It is depend upon the how much is the luminal narrowing, and it can be exactly assessed with sonourethroplasty. Next question is, EODS should be done before or after the urethroplasty? Definitely after the urethroplasty, because it will give falsely the obstructive pattern or increase in the pressure, retrosal pressure. How to give position for endoscopy when patient is having pelvic fracture? Change the table, not the patient. Move the table in that position, not the patient, so that there should not be any displacement of the fracture. Okay, we will go ahead, sir.
Yeah. So, okay. So now Sashwat, suprapubic is done. Now, after how many days you will call him and what investigation you will do?
sir, we'd like to obtain an up and downogram, RGU along with the voiding cysturethogram via the SPC. Once he's able to walk, like after is advisable to wait for at least 3 months for the injuries to stabilize.
Fine. Okay, show them.
Months we did
Show other film.
RGU with
Paras.
MC.
Paras, show all the film.
Only these films.
No, where is RUG? We are not seeing it.
RUG.
Okay. Fine. Sashwat,
Yes, sir.
you can see all the 3 films?
Yes, sir.
Chalo, explain and tell me what next.
Sir, we'd like to counsel the patient and prepare him for anastomotic urethroplasty, sir.
Yeah, what are the findings in this you are seeing?
Sir, there is
What
a
else you want
fracture.
to do after this?
There are fracture of the superior and inferior left side pubic rami, sir. And sir, actually the length of the defect we cannot make out, sir. So we are able to see the.
Then how you have decided? Then how you have decided it is anastomotic orthoplasty?
Sir, we'd like to get a MRI done to, or we can go for, sir, examination cystoscopy and up and down cystoscopy we can do, sir.
Okay, I will show you that. But before that, in these 3 X-ray, what are the findings? Tell me, na?
Yes, sir. Sir, in the cystogram, sir,
Are you
we
able
have
to
not.
see the posterior in MCU? I mean, this thing in the
Cystogram, no, sir.
voiding. So
Posterior
if
urethra
you
is
want
not
to,
visible, sir.
if you want to see that, which is the method?
Sir, we can give alpha blocker to the patient, sir.
Exactly. Yeah. So you
Or-
give alpha blocker for 2-3 days, and
Yes,
then
sir.
you go ahead with voiding cystogram. Correct?
Yes, sir.
So
Yes,
that is
sir.
number 1. Second thing, you can see the left rami, the left
Yes, sir.
pelvic bone fracture.
Yes, sir.
Correct? And
Yes, sir.
third, there is a little displacement of the urethra.
Yes, sir.
And I think there is minimal extravasation of probably the dye. Means not dye, but there is, as in the lower one. Yeah, you can see it.
Yes, sir.
Okay, fine. Just show them. Paras. Up and down
So we
cystoscopy.
did a up and down cystoscopy. I will show you the video.
What happened, Paras?
One, yes, sir.
Yeah.
Yes, I'm sharing this. So this is
So here there is a blind end.
Yes, sir.
Okay. Fine. Paras, show the next one.
yes, sir. This is done from the SPC side. So this is the bladder neck. We are not able to see the veromontanum from.
We tried to pass the guide wire, anything, but nothing was going. Yes. So now this is a situation. Sashwat or
Yes, sir.
Rajesh, now what you like to do?
Sir, we'd like to assess the distraction defect, sir. How much is the
Yeah, it
distance?
is, as you can see
Yep.
on the X-ray also, it is the same thing.
Yes, sir. Looks about, sir, more than, sir, 4 to 5 centimeter.
Yes.
There are various ways of assessing the length of stricture. Number one, VCUG and RUG combined.
Yes, sir.
Okay, so the pubic ramus width is 2 centimeter.
Yes, sir.
So measure that length and compare with the block in between the RUG and MCU or superimposed film. So that is one way. Another way is bugiogram.
Yes, sir.
From below and hugro from above, or both the dilators from above and below. That is
Yes.
bugiogram. Next is up and down scopy.
Yes, sir.
If you have a flexible scopy, you can go in. If you have rigid scopy, you can just see the viru. Beyond that, it is not possible.
Yes, sir.
Finding of cystoscopy from above, normal bladder neck, distorted bladder neck, open bladder neck. These are only 3 findings. So bladder neck is completely open, bladder
Yes.
neck is distorted, bladder neck is normal. Okay. While doing the cystoscopy or up and down scopy, I particularly, we don't have flexible, so we pass the vigru from above. This is our crude way of assessing, is that patient is requiring a pubectomy or not. So vigru is palpable, no pubectomy.
Okay, sir.
Vigru is not palpable, pubectomy. Initially, that's what we were used to do. Nowadays, we are doing in a complex stricture, MRI.
Sir, MRI.
All cases of PFUI, MRI is important. We are doing each and every cases of PFUI. It will help in assessing the periurethral soft tissue, as well as you can judge is this patient required a pubectomy or not.
Yes, sir.
So MRI with special protocols like filling the urethra with some jelly.
Yes, sir. Filling the SPC.
And filling the bladder.
Yes, sir.
Okay, and doing the T1 and T2 weighted images
जी sir.
and see up to what level the proximal urethra is coming. If
Yes,
it is going below the level of pubic bone, no pubectomy.
Yes sir.
If it is not going or remaining above only, need of pubectomy.
Yes sir.
Alignment of the proximal urethral segment and distal urethral segment, anteriorly displaced, posteriorly displaced. Is it
Yes.
close to the rectum or not? Is it stuck to the syphilis babies or not? Because that will help intraoperatively.
Yes sir.
Another indication associated with fistulas, rectal fistulas, bladder neck injuries. So there is a role of MRI. So this is the MRI in post-traumatic strictures. Then gapometry index. How to gap? The length of the gap divided by bulbourethral length.
Bulbourethral length.
More than 0.8, it is pubectomy.
Yes sir.
Less than 0.4, simple perineal repair.
Yes sir.
Okay, so these all things, and nowadays there is 1 or 2 article from Kulkarni group, 3D printing technology, published in Turkish Journal of Urology.
Okay, sir.
So we don't have 3D printing, but we have also started one new technique in where if you are not able to do the MRI due to some implants, in
Yes, sir.
such situation we are filling the bladder with contrast, filling the urethra with contrast, and
CT
doing
we can do, sir.
the with 3D reconstruction.
Yes sir.
So this is in short about investigation and assessment of the urethral gap with various ways of assessing the urethral gap.
Yes sir.
And always tell it is a progressive perineal urethroplasty.
Yes sir.
If you exactly see the length of bulbar urethra on M2 and RGU, and if it is less than 2 centimeter or near to 2 centimeter, then you can tell it can be okay with anastomotic. But
Yes,
if you have any doubt, better to tell progressive perineal urethroplasty. Anastomotic is part of that only.
Yes sir.
Okay, go ahead, Paras.
So, Gite ji, what you will plan out in this
Ji, sir.
after seeing this?
Sir, in this particular patient, I will assess the urethra by one of the technique. You also know I am doing passing Higuro from above, passing scope from below, assessing the gap, intraoperatively using the fluoroscopy. Then, if the length is too large, or if there is a gap is too large, then I will place it as a progressive perineal urethroplasty, and I will try to fill the gap with various ways of filling the gap, like mobilization of the bulbar urethra, corporal separation, rerouting, inferior pubectomy, superior pubectomy, transpubic. These are the ways for going for to fill the gap between various ways. तो इसको प्रोग्रेसिव पेरिनियल यूरेथ्रोस्टॉमी, प्रोग्रेसिव पेरिनियल यूरेथ्रोप्लास्टी बोल के मैं ओटी को रखूंगा.
Yes sir.
Okay, fine. So we are also planning. Okay.
Yes, sir.
So this is. So we have not done any surgery. Okay. Now we'll finish 2 more scenario.
Okay.
Fast. Paras, go ahead.
This is a case about a 48-year-old lady presented to our OPD with progressive increase in the symptoms of lower urinary tract, frequency, poor stream, straining with sense of incomplete void. There is history of recurrent fever with warning maturations in 6 months. Patient has attained menopause 2 years back. Patient is para 3 with 3 living issues. There is no comorbidities, no surgery in past or urethral instrumentation in past. On examination, abdomen is soft, non-tender. Per vaginal examination is normal. On ultrasound was suggestive of a prevoid of 480, PVR of 230 with thickened trabeculated bladder wall. The uroflowmetry is given. What next?
Yes, Saswat, this is a history. What do you like to do?
Sir, we'd like to proceed with cystoscopy and SOS urethral dilatation.
देखो, What you are telling is majority people doing practically, like starting the alpha blocker, giving some Evelyn vaginal cream as estrogen replacement as that she is a postmenopausal, giving one alpha blocker and giving one antibiotic. Okay, that is the usual story everywhere. But here we have not diagnosed the case. This is exam.
Yes, sir.
So in exam, what is the post-void? So 50% is post-void. Bladder is thickened. So I will ask what is the status of upper tract?
Yes, sir.
How much is the creatinine? How much is the CBC? Patient had intermittent fever. So what are the probable diagnoses? It may be meatus stenosis, postmenopausal. It may be primary bladder neck obstruction. It
Yes,
may
sir.
be Fowler syndrome. So anything, na? So it is a
Yes, sir.
bladder outlet after. It may be underactive bladder. We don't know. Okay. So for this particular patient, as the initial way of treating, I will send urine routine, urine culture specific antibiotic. I will place the catheter, start the alpha blocker, and give a trial of catheter with urinal vaginal cream daily, alpha blocker daily.
Yes, sir.
Okay. If after removal of catheter, if there is a persistent post-void residue, then I have to search for any pathology in the bladder. So next
Yes.
way of searching is urodynamic study. So what urodynamic parameter to be seen? So that is P-DATE Qmax and Qmax. So what is the pressure? If the peak flow is less than 15, P-DATE Qmax, if it is more than 50, it is high pressure obstruction. If it is less than 50, it is low pressure obstruction.
Yes, sir.
So this is a bladder outlet obstruction. Video urodynamic is a gold standard to diagnose the bladder outlet obstruction in female, provided that we have ruled out the meatus stenosis by placing the catheter.
Yes,
So
sir.
that is one of the crude way of ruling out the stricture urethra in female. Another way is scopy.
Yes, sir.
So, but isolated scopy doesn't have any role in diagnosing the bladder outlet obstruction in female.
Yes, sir.
Okay.
Fine. Yes. So Paras, tell them what we did. Paras.
Yes.
Now
So
all of you know
we
what
did a
Dr.
cystoscopy
Gite
and
said.
urethral dilatation. Patient again have similar complaint after 4 months, and the uroflowmetry was like.
So this is the second time after the dilatation. Again, patient had undergone, this was done somewhere else only. So again, patient underwent urethral dilatation. Paras showed the next one.
Patient again
So
has similar complaint.
patient has got a similar complaints. And now actually now this is the time when she came to us. Okay.
So
Shashwat. Yeah,
we
two
need
times. Yeah, 2 times
we need 3
dilatation.
investigation.
Pardon?
We need 3 investigation. One scopy, one MCUG, and one urodynamic.
Yes, sir.
Yeah.
This will resolve the problem of diagnosis.
Correct.
Yes,
Okay. So क्या किया सर बोल दो.
पारस क्या किया था?
So we did a sonography. So there was a pre-void was about 330 and with post-void of about 225 ml. There were no upper urinary tract changes. Bladder wall was thickened and trabeculated. Urodynamic study was not done. Only uroflowmetry.
So only uroflowmetry was done. There was hardly any, this time there was hardly any post-void residual urine. And every time we found out that patient has got a severe urethral stenosis. So now next what you like to do? Shashwat?
sir. we'd like to offer, sir, urethroplasty to the patient, sir.
So where you have diagnosed the obstruction? So don't tell, think over it. So either you have to go for a video urodynamic.
Yes, sir. Or a
Okay.
voiding
So,
cystourethroplasty.
so video urodynamic
Yes, sir.
means in spite of having a sustained detrusor contractions, if bladder neck is not opening, that is primary bladder neck obstruction and treatment is BNI.
Yes, sir.
If having adequate contractions and the level site of obstruction on pressure profilometry, if it is in the mid urethra, then the stricture in the mid urethra to site. So whatever you are planning, that may be the right for this particular patient. And indirect way with doing a MCOG with giving alpha blocker and asking a widening cystoprogram.
Yes, sir.
And scopy. So scopy, where is the block? MCOG, where is the block? And obstruction, profilometry, or widening widening video aerodynamic, where is the block?
Yes, sir.
So if it is in the bladder neck, BNI. If it is in the urethra, then ventral BMG, dorsal BMG, and number of types of BMG.
So during scopy, matlab that we did the injection of dye, and under CM we saw that wide bladder neck, it was obstruction of the urethra. So buccal mucosal graft urethroplasty was done. Do you have films, Paras? Paras?
Yes, sir. Yes. So it's loading, sir.
So as Dr. Gite said, most important thing is you must do either means urodynamic study and also voiding cystogram, if it is possible video one, so you know where is the obstruction. And once you establish the obstruction, you go ahead with the definite surgery.
Yes, sir.
Right?
By
See,
the
all
time
this
it is
case,
loading, there is a scenario 4. A 72-year-old gentleman presented with lower urinary tract symptoms, frequency, urgency, nocturia, poor flow since 3 months, no burning maturation or fever, no hematuria or lithuriia, underwent TURP 2 times last 2 years back. On examination, abdomen is normal. Per rectal examination, prostate fossa is flat. Blood investigation are normal. Urine shows 20 to 25 per WBC per high power field. RBC is 1 to 2 per high power field. Culture sensitivity is sterile. On sonography, prostate is 13 grams. No per tract changes. Post TURP status of fossa, pre-void of 355 and post-void of 166 ml.
yes.
Slide,
Paras, just
slide नहीं दिख रहा है Paras.
slide change कर. Okay, anyway, Sashwat, this
Yes, sir.
patient history is 2 times he has undergone TURP.
Yes, sir.
Fine. And he has got now again the similar history, difficulty in passing urine. He has got infection. Okay.
Yes, sir.
So now next what?
Sir, we'd like to prostate fossa, sir, looks open on the ultrasonography, sir.
Yeah.
So, sir, a urodynamic study would be required, sir.
Whenever patient had a history of twice TURP in patient presented with widening LUTS or any LUTS, the first thing come in minds of any urologist from new to old is patient may have
bladder neck contracture.
either stricture urethra or BNC.
Yes, sir.
So to rule out that, what you will do? RUG.
Yes, sir. RGU MCU.
So 2 important things, Ashwat. First of
Yes,
all,
sir.
patient, you must ask patient that after TURP, whether his flow was normal or not. If he says yes, immediately after removal of the catheter, for like 1 month, 2 months, he had a good stream, that means there is no urodynamic, means neurogenic bladder. And
Yes.
then he has developed the stricture or bladder neck contracture. So two tests was first is a uroflowmetry and second is RGU or RUG. Just
Yes, sir.
show the uroflowmetry. Can you just enlarge? Hardly any flow.
Yes, sir.
Okay. Show RGU. Yeah.
Sir, RGU is showing smooth narrowing in the bulbar urethra, sir, but the contrast is not going into the posterior urethra or the bladder, sir.
That can be a spasm of sphincter
Yes, sir.
along with typical post-TURP proximal bulbar stricture.
Sir,
For
we'd like
for all of your kind information, there is no stricture in membranous urethra. Stricture will not occur in membranous urethra. It is a urethral stenosis,
yes, sir.
narrowing. Stricture and stricture disease. Stricture disease and stenosis. These are three different entities.
Yes, sir.
The stricture is usually a focal with limited spongiofibrosis. Stricture disease is a lengthy stricture with maximum spongiofibrosis. And stenosis is only a luminal narrowing. Stricture and stricture disease is associated with the spongiofibrosis in the spongiosa.
Yes, sir.
At membranous urethra, there is no spongiosa.
Yes, sir.
So there is no stricture. No spongiosa, no stricture.
Yes, sir.
It is a stenosis. So whatever the diagnosis radiologist has given, people will telling bulbomembranous stricture. No, it is only bulbar stricture.
Yes, sir.
So usually it is a proximal stricture, and post-TURP it is a proximal bulbar stricture. This is also proximal bulbar stricture. If you then how will you proceed? Okay, I will tell that. How will you proceed in this patient?
So where is Rajesh? Rajesh, na?
Yes, sir. Yes, sir.
Yes, Rajesh. Now you answer. So now what you will do? How will you proceed?
So in this case, we
Yeah,
have to
tell me.
assess,
No problem.
yes, sir.
You are not going to be wrong. Tell us.
Sir,
देखो गलत होगा तो भी प्रॉब्लम नहीं बोलना है.
now in this case, we have to assess the length of the that proximal bulbar stricture, sir. For that, we need a specioscopy or from below.
So he's passing urine. So you'd like to do scopy.
Yes, sir.
Okay, Saswat, what you will do?
Sir, if there is a bladder neck in scopy,
No,
sir.
what you like to do better in this case after this?
Sir, MCU, sir, we'd like to put a small feeding tube, sir, and then obtain a voiding film.
When he's passing urine, okay, anyway, we have not done that. So what we have done is a cystoscopy. So this was a stricture.
Yes, sir.
As Dr. Gite rightly said, okay.
Yes, sir.
So there were two stricture, one distal little, as you can see, and one we had cut that stricture, and now that there is a second stricture. So that also we have cut it over the guide wire.
Yes, sir.
Now, Dr. Gite, just last comment, how you will proceed in this case in exam?
Sir, this particular patient, I will see how much the severe voiding symptoms he has, how much is the post-void residue, is clinically bladder is palpable. If all these findings suggest you positively, then I will place the SPC and go for VCUG lateral and assess the length. This is one way. Another way is I will go for to do a scopy with 6 French ureteroscope. Okay. If that 6 French ureteroscope is going from across, then I will assess the length, how much is the luminal narrowing. Usually it is a proximal bulbar stricture and post-TURP proximal bulbar stricture. The best way of treating this stricture is ventral only BMG.
Okay, fine. So all of you now have understood. We have done VIU in this patient,
Yes, sir.
but in exam you can say that you will do the assessment of the stricture. One of the way is by doing with 6 French ureteroscope, find out the exact site, how many strictures are there, what is the length of that stricture, and the best answer is to do buccal mucosal graft. Okay?
Single diaphragm-like stricture, VIU.
VIU. But in this case, as you can see, it's a double long stricture. So the best answer is to do buccal mucosal graft.
So why ventral BMG I am telling in proximal bulbar?
Sir, proximal vulvar will be difficult to do a dorsal, sir, technically difficult.
One answer. Another answer. Technically difficult because there is arch of pubic bone.
Yes, sir.
Okay. Another answer is the sphincter is omega shaped.
Yes, sir.
If you cut the urethra dorsally to inside, it will damage the sphincter.
Yes.
But if you cut the urethra ventrally and reach up to the veru also,
Yes, sir.
it will go in center place without damaging the sphincter.
Yes, sir.
Another thing is accessibility. Third thing is covering.
Yes, sir.
To that BMG, that it needs support.
Yes.
Proximally, if you go deep inside, the corporal bodies get diverted and there is a gap in between. So where to support that BMG?
Yes, sir.
Ventrally, there is a support of bulb as well as bulbar spongiosus.
Yes, sir.
So these are that's why for proximal bulbar stricture, ventral BMG, and for mid bulbar and distal bulbar stricture, dorsal BMG.
Dorsal. Yes, sir.
Okay.
Fine. Good. So we have covered all 4 different cases. And now any questions? Yeah, this was the urethroplasty.
छोटा सा है तो बता दो सर.
No, only this.
वीडियो है क्या?
नहीं, वीडियो नहीं लिया है. Not taken.
Okay.
Next time I'll just take the video and show everyone. Fine. So for the students, any other question? I think Dr. Gite has covered most of the thing. We started with the definition, classification. Dr. Gite has now completed almost everything. So you can write in your exams also. If you have got any question, please put it on your our group and we will address it. Okay?
Hello.
Fine. Okay then. Good night to all of you.
Hello, good evening, sir.
Thank you, sir.
Yeah, bolo.
Sir, I'd like to ask some questions. At the first case which we discussed, the patient presented later on with bilateral hydroureterine nephrosis, later on with failure. What could be the reason over there, sir?
What you feel? The patient is in obstructive state continuously for longer time.
Okay.
With intermittent obstruction by a VIU.
Okay.
Okay.
Yes, sir.
So that is the thing which probably result into the renal failure. That's what I feel. Sir, आप बोल दो कुछ और हो तो.
See, there are three things. First of all, patient is a diabetic. So there must be definitely some element of diabetic nephropathy. Second thing is patient has got recurrent urinary tract infection. So patient must have developed some pyelonephritis in this obstructed system. Third is, as we said very rightly, there is a back pressure changes. which has also caused reflux uropathy. So all the three things combined, and we found out that there is definitely some ureteric stenosis because of this neurogenic type of bladder. You have seen it, na? The bladder shape and everything. There were tuberculations. It
Yes,
was
sir.
a fern tree type of, Christmas tree type of appearance. So again, there was some obstruction at the uretrovesical junction. Considering all these things, these 4 factors has given rise to failure.
Failure. Okay, sir.
True, sir.
Thank you.
Okay. Okay, then. Good night.
Good night.
Okay, good night.
Thank you, sir.
Good night, sir.
Thank
Good night.
you. Thank you.
Good night,
Thanks
sir.
to Gite sir for giving us such a fantastic
Excellent,
knowledge.
excellent, excellent.
Yeah.
नहीं तो आप वो सब आपको देख के सीखे वाला है, उसमें नया क्या है?
नहीं, we do practical things, and to all the students, please understand, we are showing actually what we have done and what should be, the answer
Exam
in the
oriented.
exam. So
Yes.
this is very important. Okay.
Okay, sir. Okay. Thank you,
Good
sir.
night, sir. Good night,
Thank you.
Gite sir. Gaurang Shah.
Good night. Good night.
Yes.
Good
Bye,
night, sir.
Hiren.
Bye.